Good afternoon. Thank you, Dr. Peniston, CAIRIBU, and the University of Wisconsin for having UTI Health Alliance and our patient panel as presenters today. We recognize that we are only 5 patients among millions who suffer from UTI, and we will do our best to represent those patients through our own experiences. We are very encouraged by this opportunity to speak directly to researchers and clinicians and look forward to the collaboration this may bring. I started UTI Health Alliance, a patient advocacy resource, in January of 2023. It may sound new, but I've been thinking about the fact that patients need a voice for many years, if not decades. I kept waiting and waiting for someone to create an avenue for patient voices here in the United States, yet nothing seemed to be happening. So I thought, Laura, why not you? You see, I've been suffering from UTI since I was 2 years old. That is over 5 decades. From my point of view, during that half century of experiencing UTIs, I haven't seen any real change in the care and treatment of patients with this illness. I am struck by that fact, considering this is one of the most common infections in the US. I could tell you about my long saga with this illness, the debilitating pain and frequency I have experienced throughout my life, and the horrific procedures I've endured because of my desperation to feel better. But I'm not going to. Perhaps some of the patient panelists will go into that important perspective. I'm here to paint a broad brushstroke over the research needs of this disease and implore you to come up with some solutions, and quickly. We have been waiting long enough. The most common cry I hear from patients is this: the testing has failed me. Why am I being sent home to suffer when I have all the symptoms of a UTI, yet a negative test? Why doesn't anyone believe me? In a literature review conducted by Chronic UTI Info, a UK patient advocacy group, a current dipstick and culture tests used all over the world have been proven to be up to 90% inaccurate, resulting in false negatives. They were never developed to test for UTI. Rather, they were developed to test pregnant women with acute kidney infection and not lower urinary tract infection. The CAS criteria for infection is much too high at 10 to the 5. Furthermore, the tests only detect a small number of fast-growing bacteria, such as E. coli, and not the multibacterial infections that often accompany recurrent and chronic UTI. In fact, in a 2023 Chronic UTI Australia survey of 410 UTI patients, 92.7% answered yes to this question: have you ever experienced UTI symptoms while returning a negative urine culture? That statistic nearly matches the 90% inaccuracy reported in the study done by Chronic UTI Info. My own experience is as follows. I tested positive for UTI in my early childhood all the way through my 30s. Then I started testing negative intermittently. And then, as I got older, I started testing negative consistently. Did I suddenly become uninfected, yet have all of the same symptoms? I might add that I began seeking out doctors that would order next-generation sequencing and PCR tests. Those tests would come back positive, mostly for E. coli and Enterococcus faecalis, thus matching my symptoms. It is clear based on patient experiences that there is a spectrum of phases of this disease. Patients report acute, recurrent, and chronic phases, each with their own treatment and testing needs. Those needs need to be researched, and guidelines need to be established for how to escalate treatment and testing as the disease progresses. I know I have experienced each of these phases, and each of them has resulted in an increasing burden on my life and on the medical system. In the Australian study, it was found that on average, patients spent 8.5 years in the acute phase of this illness. That is a long window for patients to hopefully receive care that would eradicate their illness and send them on their way to enjoy their lives. Yet that care seems elusive and vastly misunderstood. Many patients feel that if they had been given enough antibiotics and at a long enough duration and strong enough dose, their infections would have been eradicated after the first or second onset of acute symptoms. I am not going to go into an antimicrobial resistance discussion here, but let's rethink this problem. Perhaps the issue has more to do with not giving full enough antibiotic coverage to begin with upon first or second infection, therefore injuring the bacteria and creating a resistance issue. This is definitely a topic for another talk. The physical pain was also documented in the Australian study. On a pain scale of 1 to 10, nearly 50% of respondents rated their pain as a 9 or 10, which is in the range of excruciating or unbearable. On average, the 410 participants rated their pain at nearly an 8 on the pain scale, which is in the range between very intense and utterly horrible. This is what causes the desperation so often spoken of from patients. When clinicians don't believe us, that causes another pain, a mental anguish that is utterly unspeakable. In preparation for this talk, it has been difficult to distill down the focus into 3 distinct areas of need. The problem is endemic, and the need is greater than can be conveyed in this short hour. Here are the 3 distinct areas of focus and need that I've chosen to highlight. The testing situation needs to be fixed. It is time to cease relying on inaccurate testing as a diagnostic tool. Until it is refined, clinicians need to listen to their patients and treat based on symptoms. This is vital to preventing a lifelong sentence of chronic UTI. Second, there is a spectrum of phases with this illness, acute, recurrent, and chronic, and they need to be addressed differently. We need to establish a baseline treatment and how to escalate that treatment through each phase. And third, the physical pain is so great, yet pain management is most often ignored, and pain medicine has not yet been developed specific to this illness. This causes a mental health crisis as well as a physical health crisis. In fact, in the Australian study, 1 in 10 of the patients reported suicidal ideation or attempted suicide. I have called this talk UTI Through the Lifespan, a patient perspective, because we are going to speak to you from childhood through postmenopause. Because I have experienced my illness since age 2, I will touch on the experience through my eyes as a child and how that has impacted my entire life. I can't tell you that I remember having a UTI. I must have, because what I can remember is being alone in a doctor's office with an older man who was sticking something in me down there and causing me to swell and swell and swell. I remember the pain and the fear and wondering where my mom was and wondering why this was happening to me and wondering why she left me to experience this trauma. I couldn't use words at that time to describe what was happening to me, but more than 50 years later, I can tell you the effect of what I now know was a bladder hydrodistension. I had no anesthesia, no parental support, and no explanation of the procedure. I was 4 years old. I didn't know until my 20s what had happened to me, but it affected my life as a medical trauma nonetheless. I spent years avoiding doctors. I had trust issues regarding intimacy. And to this day, I don't really believe that I will be helped by the clinicians I seek out to try and control my UTI symptoms. I also believe this experience affected my life in untold ways that I'm just now beginning to uncover. I certainly hope this doesn't happen to another 4-year-old little girl. My mom is no longer alive, but I've often wished I could ask her what it was like making decisions for her sick little girl. What must it have been like as a parent to say yes to a procedure like that? I have to believe that she was also in the dark about this procedure and how it was carried out. I know she would have protected me otherwise. Perhaps our next panelist, Devin Sharon, will be able to speak to that issue. Devin is the parent of a young daughter suffering from UTIs.
Thank you, Laura. Thank you for everyone who is participating and I'm very glad to be able to share in this event. Ever since my husband and I began potty training my daughter, there was noticeable problems with accidents. It was pretty easy potty training her older brother, and so we expected the same with her. It was frustrating for us as we tried to prepare her for school at almost 3 years old, and she still continued to wet herself regularly. There were also many times we were out in public, inconveniently cleaning up after an accident and fumbling to get her into clean, dry clothes. We originally just assumed Indigo was taking longer to get it or just being stubborn. It almost seemed like she just didn't want to do what we were telling her. Now I recognize she was not listening to her body for signs she needed to pee. This has been a continuous problem ever since, and she's now 8 years old. She always carries spare underwear, pants, and socks with her at school. The symptoms she has experienced have been needing to urinate immediately and having an accident if she was not near a toilet, noticeably smelly urine, complaints of her vagina hurting, and sometimes telling us it hurts when she pees. I also see her repeatedly sit down on her foot to stop the flow and wait until the feeling passes before she can get up. I recognize this because I did it myself when I was young. I would have accidents as a child quite often and vaguely remember having bladder infections. Unfortunately, my mother can't remember this to confirm it. But even in my teens, there would be times when I wouldn't realize I needed to use the bathroom until it was nearly too late. All of this seems like a chronic problem I somehow passed down to my own child. In our house, we put health through proper diet at a high priority. We all eat numerous kinds of fermented foods and avoid eating anything that would be inflammatory. We use probiotics and prebiotics with regularity to maintain a healthy gut biome. Antibiotics are not something we take lightly, and our children have almost never had any. The one instance during which Indigo had a short course of antibiotics was almost 2 years ago when she was taken to the pediatrician and had her urine tested. She had been complaining about pain during urination, and it seemed more of a developed problem than past occurrences. The results came back that there was E. coli found in her sample, and my husband and I decided, if this is what stops this from ever happening again, it's worth it to try the antibiotics. Unfortunately, it was only a temporary relief to her situation. After relating this seemingly chronic problem to a friend shortly after the antibiotics, I was told it could possibly be a surgically corrected condition. Someone she knew had a daughter with similar issues and visited a pediatric urologist, had some surgical procedure, and she was cured. Could it be that easy? Is this something I needed and now my daughter can benefit from? Obviously, surgery for a child is not ideal, but if it could save her from years of problems, I'd be willing to consider it. I got a referral and booked an appointment with the nearest pediatric urologist 2 hours away, and we went. She did a urine test. I explained her symptoms and everything I see her doing that I remember doing as a child. It seemed to be a typical doctor visit. We were told she's holding it too long, she needs to work on emptying her bladder fully and drink more water. I was never told what physical problems might cause this, and the urologist never mentioned anything that could be fixed through surgery. I left wanting to know more of the science behind the issue and feeling like I didn't know any more than when I arrived. Here we are, she's 8 years old. She takes D-mannose every day. She doesn't complain of pain, but every once in a while. Most times we can smell her urine long after the toilet has been flushed. All we can do is stay on top of it and encourage her to drink more water and cranberry juice, pee when she needs to, and try to fully empty her bladder. We can only hope she is not in more pain than we hear about. After hearing the experience of others, I feel so grateful that the situation is not worse, that she is not in constant excruciating pain. But could this get worse as she gets older? I don't know what I would do. I don't feel like taking her to the pediatrician gives us any more information than we already have. As a parent, I look at my daughter and I think how much more work she is than my son. It feels like there are already so many things that burden a female, and now this is added to the load. We feel helpless when she says her vagina hurts, and all we can say is, you're not peeing when you need to, and you have to drink more water. And we are just hoping that she'll work harder to do these things, and that will correct the problem. It seems as though we are just constantly working to keep a UTI at bay. This is clearly an issue that affects many more women and girls that are willing to speak up. I didn't realize I had a problem that was commonly shared. My husband and I are hopeful to learn about more options or information about female urinary health so that Indigo might benefit from what we learn, and again, save her from possible future struggle. But as of now, it doesn't seem like we can rely on our care providers for any of that. Thank you for your time and listening to my experience.
Thank you so much, Devin. I really appreciate you sharing. I'm going to hand this over to Faith now. And Faith is joining us from the road. Faith happens to be my daughter. Are you there, Faith?
Thank you everyone for having me today, and I'm very excited to share my story, and I appreciate the opportunity to express my concern with all of this. My journey with chronic UTIs and bladder pain started right around the new year, at the beginning of 2020. I was 20 years old and had only a UTI once before. For no apparent reason, I suddenly developed extreme pain, burning, and urgency in my bladder. I immediately knew I had developed an infection, but when I went to the doctor's office, they told me the test came back negative and that I did not have anything wrong with my bladder. In fact, I was asked multiple times if I was drinking enough water or simply just stressed out. To be told I was not ill left me feeling alone and afraid. I continued on with no treatment until I got to the point where I developed a kidney infection and became extremely sick. I was left with no choice but to do my own research into my illness and try and treat my symptoms myself. Many trips to many different doctors left me feeling hopeless. No one was able to help me get better, and I was often told that there was nothing wrong with me. Thankfully, I have gotten to a point where my symptoms are under control, but keeping myself out of pain is a constant battle that I will likely have to deal with for the rest of my life. Although I had all the symptoms of a UTI and at one point a kidney infection, no standard urinalysis tests or cultures run by a doctor ever came back as indicating an infection for me. At my sickest, I could barely walk due to the pain in my lower back and was riddled with a fever, nausea, and vomiting, in addition to severe bladder burning, pain, and frequency. I also developed extreme pain in my hip due to the inflammation I was experiencing. Despite having all of these symptoms, the doctors I saw still claimed I was perfectly healthy. Thankfully, I found an alternative medicine doctor who was willing to prescribe me long-term antibiotics. I went on a 6-month-long course of high-dose nitrofurantoin, taken 2 to 3 times per day. These antibiotics, combined with supplements that disrupt bacteria's protective film, called biofilm, were the only thing that allowed me to get well again and allowed my quote-unquote hip problem to disappear magically. I now manage my symptoms and keep the infections at bay by taking daily supplements such as D-mannose and serrapeptase that reduce inflammation and prevent E. coli from clinging to the bladder wall. Needing to be vigilant every day about taking these expensive, inconvenient supplements has had a huge strain on my time, energy, and finances. I truly believe I would not be in this position if I had received the correct dose of antibiotics when I first developed symptoms back in 2020. So many women suffer from similar journeys to mine, yet there is no effective treatment and scant medical literature on the matter. Awareness needs to be raised for this issue, and research must be done. Yet, perhaps due to lack of funding or interest, we seem to be left alone to suffer. Hundreds of thousands of women are in dire need of help, and we are not getting it. We need change. Our healthcare system needs to start listening to its patients' concerns, and much more research into chronic and complex UTIs needs to be funded and conducted. Thank you for listening.
Thank you so much. Appreciate you joining from the road. All right, and now we're going to hand it over to Rochelle.
Can you hear me?
Yes.
Okay. Thank you, Dr. Peniston, CAIRIBU, the University of Wisconsin, and Laura at UTI Health Alliance for allowing me to share some of my chronic UTI experience with you today. My name is Rochelle Keating. I'm 46 years old, and I live in Pennsylvania with my husband and our 3 sons. While I may appear well and put together, I am far from it. As a UTI in the fall of 2017, when I was 40 years old, was left untreated due to an unreliable dipstick test and standard urine culture. My story spans over the last 25 years, when I was 21 years old and pregnant with my first son, and developed a kidney infection and kidney stone at 33 weeks pregnant. That is a harrowing story in and of itself, as the life of my unborn baby and my own life was on the line, and we are both lucky to be alive. However, I never could have imagined what I would go through and be put through, all because of a negative dipstick test shortly after my son's birth. This was the first time I was subjected to an investigational bladder hydrodistension, followed by DMSO and heparin installations and a prescription for Elmeron. In the following years, I went on to develop 3 UTIs in 1 year, again while pregnant with my second son and shortly after his birth via emergency C-section. The UTIs were all cleared with antibiotics. For the sake of time, I'll fast forward to 2017, back to the UTI that was left untreated. It is hard to adequately convey the torture of having an untreated infection, but I will give you a glimpse into the last almost 6 years since it began. I began with classic UTI symptoms: urinary frequency, burning urination, and bladder pain. Because my dipstick was negative, I was told no treatment was necessary, and I was sent on my way in pain, in shock, and confused. With each passing day, the symptoms became worse, more widespread throughout my pelvis. I developed a low-grade fever, back pain, urinary retention, could no longer sit, and was in complete agony. I was unable to sleep, eat, think, barely able to do basic tasks. Even walking became difficult. This went on daily for years. I was gripped with anxiety, as no one seemed to know what to do with me other than offer invasive procedures, anticholinergics, and antidepressants. My life was crumbling, falling apart in front of my eyes. I was in misery. I was no longer the mother, wife, and friend I once knew, doing it all and longing to be her again. I cried every day, begging for God to take me, begging for God, the universe, anyone to hear my pleas and end the off-the-charts, 24/7, relentless pain. I was in an endless pursuit of finding a doctor that could help me. In the hands of quote-unquote experts, I endured 2 more hydrodistensions, nerve blocks, trigger point injections, excruciating pelvic floor physical therapy for years, and perhaps the most egregious, a hysterectomy. None of these surgeries or medications helped, not one, not even a little. The impacts on my husband, children, the huge financial burden, traveling across the country and nearly out of the country are just a few more things that have greatly affected me. My travels out of state were because my local physicians had nothing more to offer other than repeated procedures, diet modification, and insulting advice on personal hygiene. One urologist said, I just needed to have a glass of wine and do some yoga. He did not believe I had an infection, even when the PCR testing that he suggested came back positive. I was finally able to get further testing through PCR NGS and began treatment in 2019. This testing enabled me to obtain treatment by a physician who understood persistent infections and how to treat them. Antibiotics were the only thing that helped me and brought complete relief most of the time. However, because this infection was left to fester for years and years, it has become extremely difficult to treat. In closing, from my experience, the reliance on outdated, incompetent testing and not listening to patients' symptoms is what put me and thousands of others in a situation where we are fighting for our lives. When people are contemplating suicide, completed suicide, dying of sepsis, losing their jobs, relationships, marriages, and having to go on disability over one of the most common bacterial infections in the human body worldwide, we have an enormous crisis on our hands. The standard urine culture and DIPs have failed millions. We are desperately in need of better testing, UTI research, and treatment options that provide a complete cure. I believe with 100% certainty that if my UTI in 2017 had been properly treated based on symptoms and not reliance on a test, I would not be in the position I'm in today, nearly 6 years later. Thank you.
Thank you so much, Rochelle. Appreciate that. And we'll hand it over to our final speaker today, Kathy Hutner. Kat, it's all you.
Hi, Laura. Hi, everyone. Thanks for having me. Rochelle, I'm having PTSD listening to you, and you have my heart for that experience. It's terrible. I lived a lot of that. Collect myself for a minute.
Hard. You got it. You got it.
Okay. Well, I'm 65 years old. And well, I had the occasional UTI during my college years. I'm sorry I'm so emotional, I didn't anticipate it, but listening to everyone, I just am reliving the horror of this illness. And I feel so fortunate for being able to be here today and be in the position that I'm in. But I have such empathy and sympathy for everyone who continues to struggle with this. Okay. Well, I had the occasional UTI during my college years. I was essentially free from UTIs my entire adult life until my late 50s. And this followed a total hysterectomy when I was about 45 years old. I speculate that may have been related to the later onset that I experienced of persistent recurrent UTI, with frequency of occurrence increasing each year. By the summer I turned 60, I had back-to-back UTIs over the course of a 3-month period. Always, for me, unlike many of the ladies speaking today, when I had symptoms, I always had a positive dip, always. And the culprit for me always was E. coli. My urologist at the time recommended prophylactic antibiotic treatment, and I started on daily doses of nitrofurantoin. I tolerated that. It was low dose. I tolerated that with no problem for a 2-year period. And during that time, I had recommended medication holidays where I would go off it and go back on it. After the second medication holiday and recurrence of a UTI during the time of that holiday, I found I could no longer tolerate nitrofurantoin, which now gave me disabling, massive headaches and immobilizing fatigue. Due to several other medication allergies that I have, my UTI treatment options are grossly limited. I, at that time, and still do, lived in dread of the next inevitable occurrence. It was always just short weeks to days away. An offhand comment by another urologist about the existence of a vaccine in Europe led me on a single-minded search to investigate this option. I found encouraging evidence published in reputable medical journals, including the American Urological Association's Journal of Urology, that remission had occurred for many, though not all, patients with this vaccine. Determined to try it, I found my way to the Forbury Clinic in Reading in the United Kingdom. So I had to deal with other countries to get relief from what I was experiencing. I am now post-vaccine treatment for 9 months. As of this writing, I have not had a UTI recurrence to date since starting the Euroimmune vaccine in April of 2022, which for me is a miracle. It's a miracle. My experience with medical specialists has been mixed. I have had urologists who were caring but unable to offer me effective treatment once the US standard of care protocols had been exhausted. I've had urologists, unfortunately, who have been unavailable and seemingly unwilling to help. But I have also had urologists who have been compassionate and who have partnered with me, offering support and good communication, even while they could not offer me an effective course of treatment. So far, the Urimmune vaccine that I obtained in England and started in April of 2022 appears to have effectively staved off UTI recurrence for an unheard of, for me, 14 months. Urimmune does take a commitment to complete treatment. It requires a daily sublingual dose for a minimum of 3 months, and in some cases 6. And that vaccine does require refrigeration, which during the period of treatment can affect your ability to travel somewhat, but I am happy to deal with that. Nonetheless, I count each day as a blessing, every day, and can hardly believe I now have back a quality of life that I had only dreamed of before. I also continue treatment with estradiol cream. I don't know if I'm saying that right. 3 times a week, and daily D-mannose, both of which I was taking prior to Urimmune, and neither of which had discernibly impacted the frequency with which I had developed infections prior to treatment with Urimmune. I mean, I continue taking it now almost as a talisman, you know, just because I don't want anything to change. UTIs had taken over my life. I was desperate. I was never free of chronic recurrence. I was unable to travel. It impaired my ability to work. It affected my marriage and personal relationships. I was always sick. My anxiety was unrelenting. Based on my personal experience, I believe the impact chronic recurrent UTIs have on quality of life is often significantly underestimated by the US medical community. While the Urimmune vaccine does not result in remission for all chronic UTI sufferers, I believe it is an option that can be effective for some. It should be available in the US as it is currently in England, Canada, and Europe, and other treatment options, including other new vaccine options that are now being tested in Europe, should be available here in the US as well. Let me leave you with these questions. How do we make this happen? Do you in the medical and research communities have some ability to advocate to bring these treatments here to the US to women who are suffering? Is there a roadmap to make this happen? The US clearly needs to step up and take chronic recurrent UTI seriously and embrace a broader range, of resources and treatment options for women. Thank you so much for having us today and for hearing our stories.
Thank you so much, Kat. Your reaction to hearing everyone talk mirrors my reaction after we had a rehearsal on Sunday. And I truly can say that I was kind of thrown into a PTSD state and unable to function for a couple of hours after the rehearsal, because this is very hard for patients to talk about. Most patients keep it very much close to their cuff, and they just do not talk about it. So I really appreciate each of the patients sharing. It's extremely challenging, and you're very brave. All right, so in summary, testing needs to be addressed immediately. As I stated earlier, and you've heard repeatedly from our panelists, the current dipstick and culture tests don't work. Why scientists would want to rely on testing that has been proven to be up to 90% inaccurate is beyond my understanding and the understanding of those suffering worldwide. I know that many physicians are not happy with the advanced testing that is available now. Testing like MicroRegen DX, Cirrus, Pathnostics, and many others that utilize next generation sequencing and PCR technology. In addition, there is enhanced quantitative urine culture. I don't understand the difficulty in accepting these tests when they could help millions of people who are suffering. Please quickly figure out testing that is effective. In the meantime, please do some deep listening to patients and diagnose and treat based on symptoms until testing has been refined. Second, we'd really like you to research the spectrum of this illness and prepare treatments specific to the phases that patients report as acute, recurrent, and chronic. In fact, UTI Health Alliance is very much interested in collaborating on research regarding prevalence in the recurrent and chronic stages of this illness. Third, the physical pain of this illness is a crisis in and of itself. It has to be addressed alongside treatment for the infection. The mental and physical anguish are real and need to be treated as such. Pain needs to be addressed as a critical part of treating UTI. And finally, there are patient advocacy groups, and Dr. Predniston mentioned this at the beginning. There are patient advocacy groups that have already done valuable research, which could be useful to your progress in treating this illness. Rather than recreating their work, perhaps it would be helpful to collaborate with them for more expediency and patient perspectives. The groups are Live UTI Free, Chronic UTI Australia, and QTIC. We thank you so much for listening to us. We are relying on you to help us, and there are many of us worldwide that are anxious to collaborate with you in making change. Please feel free to reach out to us to help facilitate any research you are interested in undertaking. Thank you so much. And should I stop sharing here?
Yes,
Dr.
yes,
Predniston?
please.
Okay, you got it.
Thank you so much to all of you. I echo what Laura just said, your bravery for speaking out and your willingness to talk about some pretty private things and some things that are frustrating you. I appreciate your honesty. And I think this is the beginning of something that can continue. And what we hope to do is create more platforms for this kind of crosstalk. There are a lot of clinicians and scientists on the call today. We will follow this up in just maybe 6 to 8 weeks or a little longer with another panel where we will ask clinicians and scientists to respond to a lot of the things that you raised here today, and to also tell you about some of their frustrations and some of their concerns and what barriers they're facing to solving this problem. It's a huge problem, as you know, and might not just involve the lower urinary tract. There could be systemic factors as well. So it's a tough puzzle to crack. I think what I would like to do now in some remaining time to make this a really richer experience is to first ask if there are other patients who would like to briefly sort of chime in and talk about their experiences. And then I'd like to ask if there are clinicians on the call who would like, again, to briefly sort of talk about some of the things that were raised or respond, knowing that you'll have another opportunity to do this. And then finally, I'd like to ask some of the investigators on the call if they would like to respond or again, provide some thoughts here. So if that's acceptable to everyone, I would like to start by asking if there are other patients on the call who'd like to share some of their experiences. I guess you don't have to be a patient. You could be a provider or a scientist that's had UTIs as well. Is there anyone else who'd like to speak on that?
Hey, I can say something. So I'm Nicole. I'm a scientist that studies UTI, and it's kind of serendipitous that I ended up studying this disease because I actually almost died of a kidney infection when I was a teenager. And I didn't go into my career thinking that I would end up studying this disease, and I'm very happy that I am now, especially after hearing all of your stories. But the same thing happened to me as to your daughter, basically, but mine went septic, and they actually gave me a shot of Cipro directly into my kidney, which I've heard urologists tell me, what was that? And then I went into toxic shock, and my mom basically had to put wet towels on me all night, changing them every like half hour to keep my fever down, so that because my fever was up extremely high. And we called the hospital, and they told us there's nothing we can do for you, just put her in ice bath. But I was like a 17-year-old and I did not want to go into an ice bath, so my mom did that, and she saved my life, right? And so yeah, I think it's one of the things that I think is important is women doing research for women too, right? Like, because I can not identify with every one of you, but at least with some of you on that. So I just want you to know that, like, we as scientists, like, we care a lot, and we're really trying to do this work to make everyone's lives better. So yeah, thanks.
Nicole, that's, I know Nicole is a scientist, and of course, we'd never talked about this before, so I'm happy you had this opportunity to share that experience, and it just adds weight to what all the other patients here said today. I'd like to ask if there are clinicians here who would like to we'll take 5 minutes for clinicians and then 5 minutes for scientists afterwards, who would like to respond or just sort of offer their thoughts.
Chris, this is Linda Brubaker. I'm happy to. This is Linda Brubaker. I'm sorry, I was on mute there. Thanks for the opportunity to talk. Although I've recently retired from clinical practice, the stories that we just listened to were what I listened to day in and day out. And there's a feeling of helplessness for clinicians because you really, really want to help this individual get better and have their quality of life back. And we don't have great evidence about the best way to go about providing best care. And because clinicians are used to being seen as problem solvers and effectively solving problems, the behavior you may begin to see is that clinicians sort of engage and get distanced from that patient. And when patients begin to feel that, that's time for you to think about seeking out another clinician. I would just recommend that. It's not that they're bad people, it's just that they're kind of at the end of what they can intellectually offer to you. So I, as a clinician, am so eager, as a recently retired from clinical practice clinician, so eager to see that we can test better, detect better, treat better, and incorporate patients' values into treatment plans. Some people are pro-antibiotics, some people are not pro-antibiotics, some people are interested in doing lifestyle modifications, others not. Some are eager to use a variety of supplements, others not. And given the lack of evidence, there's not a single right way to do this. And so incorporating patient preferences and values into treatment for any form of UTI, I think, has been critically overlooked. And hopefully we can see some real progression in science. And, you know, we've got some really, really talented cutting edge research teams on this call. And if everybody can avoid staying in their silo and just thinking that what they're working on is going to be the magic answer and stay in this collaborative, this rich collaborative environment that's been created, I think we can really do better by patients. Thank you, Chris.
Very well said. And certainly from someone like Dr. Brubaker, that's very good advice and very good insight. Is there another clinician who would like to weigh in with comments or thoughts? Another urologist, maybe? And thanks, Dr. Brubaker, for sharing the fact that clinicians are frustrated and that clinicians don't have all the answers. And this is difficult when, as you said, they're supposed to be the problem solvers. And what I don't like to hear is when they give advice because they feel they have to give advice, and then it's just stupid, like drink a glass of wine and relax. That's just silly. I'd like to open up the floor to scientists, to investigators who are looking at this. Nicole Denisko spoke earlier. Dr. Advani, I wonder if you'd like to chime in here.
Well, thank you for calling me out. I was tempted to. I want to first thank all the patients here, patients and families who shared their story. I know it's not easy to relive that moment and go back to the situations that have caused you so much pain or continuing to cause you discomfort and pain. I don't have a solution for you, but I definitely have devoted my life to studying, my career to studying UTIs. What I found in my research, and it's something that I heard a lot in the patient stories today, was that UTI doesn't fall into this dichotomous yes, UTI, no UTI. It's kind of on a continuum, that there are many other symptom manifestations that we have not been able to capture or understand. And so that's something that I'm really interested in. And I hope that that can provide some answers so that people don't always try to put you in a bucket.
Thank you. Other scientists who've devoted, Dr. Wolf.
Chris, yeah. So for those who don't know, the Eurobiome field, so to speak, got initiated when I walked up to Linda and said, we have two words in common, E. coli. I'm a basic scientist. I'm a bacterial geneticist and physiologist, and I never really thought about urinary tract infections until I talked to Linda. And together we've been trying to foster a whole new field, a bunch of researchers and clinicians that recognize there's a problem. What we've done so far is really to demonstrate that the old dogmas are terribly wrong. I have to say that when I got into the field, I was horrified by what I knew, because it seemed like everything that was being done wasn't based on any real scientific evidence. So at this particular point in time, we at least now know that the old model's wrong, because a major assumption was incorrect, which is that the bladder was sterile in the absence of an infection. I mean, it's nonsensical. The bladder it's got a hold of the outside. How in the world could it possibly be sterile, right? So at least now we know that we need to be looking at the microbiome as a whole. In fact, what I've been trying to promote is the concept of ecology. And I've begun to hear others use the term. That is, instead of looking for instead of looking for the pathogen and trying to kill it, rather try to understand the entire ecological system. Our bladder is no different than any other niche. It's an ecological system that involves the host or hostess, right? The immune response. It involves the pathogen or set of pathogens. But it also involves the rest of the microbiome that's present, right? And so I heard, this whole business about giving more antibiotics early on, that may be useful, but in the long run, I don't think it's the solution, the ultimate solution. The ultimate solution is to understand the environment in any given individual, and then using, perhaps at the very least, if you're going to use antibiotics, also an attempt to restore what should be a normal, healthy microbiome, or not just microbiome, but the entire ecological system. The problem with that is that it's a long ways off.
Thank you, Dr. Wolf. I think this is a well-rounded sort of ending to the seminar today. This is just the beginning. This is just the beginning of a dialogue. Thanks to Laura and the patients who are here today, and to the clinicians and scientists here today. We have a wide breadth of experience. This is very emblematic of the type of community, the diverse community and interdisciplinary community that's going to be required to solve this problem. And there are lots more that are not here today. So we are in touch with them. We are putting out the calls to them. The CAIRIBU community is trying to organize and galvanize some momentum around this, and we're doing it. So I'd like to thank everybody for joining on this call, and stay tuned, because we will follow this up and hopefully can continue to engage patients to an even greater degree as we move forward. So continuing the great work of people that came before us, Dr. Brubaker, Dr. Wolf, and all the others who are doing this now. Thank you all for making this a really successful seminar.